Yes, actually, there are several relevant updates since the last guidelines. So we published the ESOC guidelines on cerebral venous thrombosis in 2017. So since then, we do have several interesting developments in the management and the treatment of the disease. One of the most important is probably the decompressive surgery prospective study. This was also discussed in this session by Professor José Ferro. This study was a prospective study including more than 100 patients with decompressive surgery and severe CVT all across the world. And this study, indeed, we could confirm the data from the retrospective studies, suggesting that patients with cerebral venous thrombosis really benefit a lot from decompressive surgery, because it is not only a life-saving procedure, but actually very few patients are left with severe disability, because these patients, if they survive the acute phase, then they really improve during a long term until 12 months. They still continue to improve, and that was also shown in the Decompress 2 study. However, indeed, what was our suspicion that retrospective studies could have some publication bias, suggesting that the treatment was better because, patients that do worse are less likely to be published and assessed in retrospective analysis. Indeed, that was also confirmed. So the mortality rate was about 1/3 of the patients, still patients receiving decompressive surgery. So the mortality rate was higher than what was described. And although still very few patients are left with severe disability, the outcomes were also not as good as in the retrospective analysis. But still, the conclusion is confirmed, and it's very valid that patients with CVT and impending brain herniation, even if they present severely, like unilateral or even bilateral fixed pupils, coma, etc., because many of these patients were included in the prospective study, these patients still benefit from decompressive surgery. But indeed, the mortality rates and even the disability rates are a bit worse than what was described before. Another interesting development is, of course, the use of DOACs. That was also discussed during this session, and also, of course, during the plenary session with the presentation of the SECRET trial, the pilot phase. Indeed, we do have the RE-SPECT CVT study. It was published in 2020 on the use of dabigatran in patients with cerebral venous thrombosis. It was not a trial that was designed to show non-inferiority in the statistical point of view. It was a very pragmatic probe design trial, but still it shows that it is good. It is probably as good to do DOACs, because the recanalization rates were very similar, and also the hemorrhagic complications and the thrombotic complications were very low in both arms. So it is reassuring that probably we can use, in this group of patients that was assessed in the trial, we can use DOACs, of course, if there is no other contraindication for the use of these medications. And now with the SECRET trial, although few patients included, it's an even smaller cohort, but it used rivaroxaban. It had some differences, interesting differences. Patients could start immediately after the diagnosis, DOAC, and also there was an assessment of other outcomes, more patient-oriented outcomes, headache and cognitive complaints and other outcomes. So it is still interesting data that shows that probably in the future we should be more careful in assessing these outcomes in patients with CVT, because patients with CVT are young, active patients, and using the ranking scale in this context is probably not as good as we should do. So we do know that about 80% of patients have a ranking scale 0 to N after cerebral venous thrombosis, but about 60% have neuropsychological complaints, depression, epilepsy, headache. So probably we need to be more careful about these outcomes in the future. And this trial, although small, it also showed us that it is possible to assess these outcomes.